Yeah, hi all. So this is the port positioning what we do in a robotic bilateral inguinal hernia when we have to do. So these are the three ports. One is supraumbilical, and other are almost like 8 centimeters on either the right and the left side. So these are the 8 millimeter robotic ports where we use for doing any inguinal hernia where we are doing a RTAPP for a primary inguinal hernia or we are doing a RTAPP for a recurrent inguinal hernia. So these are the ports. The thought is very clear that these three ports are essential for doing it, and after doing that, there is a time to dock the robot. This is an XI model. It has got 4 arms, but in an inguinal hernia, we'll be using only 3 arms out of it. So these are the 3 arms which are being proceeded towards the patient side, and this is how the person moves the cart from behind and try to target it on that place. So when the 3 arms are there, then it gets oriented that we have to put all these 3 arms in these 3 ports. One is for the camera, which is the central arm, the other port is on the left and for the grasper, and the right is mainly a scissor. When we finish the surgery of this thing, then a needle holder is put on the right side so we can put the scissors in place. We normally do, if it's a bilateral hernia, single flap technique, and single flap technique because it helps for a greater visualization. These are the sockets how they mount on that trocar, and that then it can be guided with this. There is a telescopic trocar what you are seeing, and after the telescope trocar has been put, it is just ready for the docking part when we have to put the left and the right instrument. So when this whole procedure is done, after that we can just see how orientation is done to see the target area, and once the target area is complete, then the other two trocars are being the instruments are being put, and instruments are being put. So now see, this is docking happening on the right side of the instruments, and there is a socket in that which goes and click it so it can be perfectly done. So only 3 arms are due. The 4 arms can be taken on the other side, which can be moved out. As you're seeing, it is being moved. Now the patient is practically ready and docked for starting a bilateral inguinal hernia. This is a case of post-radical prostatectomy, left inguinal hernia. So it is sometimes very difficult to find a flap after a post robotic radical prostatectomy, but we were lucky in this case that we have a flap. Otherwise, we have to convert these patients after a diagnostic lab into an open surgery because there is no flap. So if you are seeing, I'm trying to make a flap almost 4 to 5 centimeters above the hernia, so I can get a good flap and do a dissection. If you see the precision of this dissection, you will come to see that how we are able to go between the layers of the fascia transversalis to create a perfect flap. So by gradual dissection, I'm trying to, with sharp scissor, and the most important in this kind of inguinal hernia is that my right foot, which has got the cautery, it's clicking at a speed of only seconds. It just give a buzz out. So you get a perfect hemostatic picture. And this is a recurrent case. Recurrent means it has been operated for a radical prostatectomy. So the planes are coming up, but they are not as virgin as you would expect. But robot in these cases helps you precisely by sharp dissection, by short buzz to go in the right direction. And as you approach the medial side, you will find that you can see the Cooper's ligament. This is the lipoma of the cord, which is very important to remove, as if it is not removed, it will lead to a pseudo hernia and you will have a recurrence. So I'm trying to get over to it and removing this direct component as well as the lipoma of the cord. Soon it's going to be defined with this beak-like scissor. If you are seeing in a short burst, I'm able to make a beautiful plane in this kind of a non-virgin tissues. and trying to define the cord structures. And if you can see the peritoneum, I'm just going above that and taking it down. So you have a very less space, but with this angulation of beak like scissor, you are able to appreciate that how this dissection is becoming cleaner and cleaner with short burrs. That is the trick. Just tap it and forget it. Don't have to have long burrs. You can see the nerves also. If you see laterally on the psoas, these are the nerves. So the covering has to be left over the nerves, because if you don't leave the covering, you're going to catch a lot of things. Now when the dissection has been done on the left side, this is a mesh 16 by 12 mesh. It takes in its own thing. We have a flap. We are trying to organize that, but the space is constrained as compared to a virgin hernia, because the planes are not that easy to open as compared to this. But after proper dissection, we were able to spread a good mesh, and so all the myopectinal orifices, the direct, the indirect, the femoral, and the space of Ritzius was able to be defined so well, and the mesh was in perfect space. So after this dissection, we were happy to close the flap. Closing the flap, we do it by V-lock sutures, 2030. We prefer 30 V-lock sutures because the peritoneum is very thin. And if you see this technique, what I'm showing you, because of the thin peritoneum, I am taking the flap in a very different way, not taking edge to edge. This really helps for the flap not to tear, because if you take edge to edge in such thin peritoneum in recurrent cases, it is going to tear, then you're going to have a lot of problem. Always the pressure when you are suturing is 8 millimeter, so you don't have too much of traction when you are using that into it. Slow gradual movement, slow tightening, and if you can see how fragile is the flap. So these kind of 30 V-lock sutures really helps to get a perfect kind of a closure. And thank you so much.